Philip Balash, member of the panel.
I'm Deputy Catherine Curtis and I'm the Vice Chair of the Assisted Dying Panel.
So I've invited Deputy Curtis to join us today for the first section of questions, which will be around assisted dying. So she's going to stay for those questions and then she's going to leave. Minister, if you could introduce yourself and your officers, please.
Okay, well, if we start down the end with Peter.
Let's start with yourself,
No,
for the records,
okay,
yeah.
sorry, yeah, Tom Binet, Health Minister.
Sure.
Hello, Peter Bradley, Director of Public Health, Medical Officer of Health.
Hi, Ian Tegadine, Director of Workforce.
Ruth Johnson, Director of Health Policy.
Peter Gavey, Chief Ambulance Officer.
Martin Carpenter, Director of Health and Informatics.
Andy Weir, Director of Mental Health, Social Care and Community Services.
And Mr Carpenter, we're aware that you need to leave, so we've brought that section of the question plan
Thank you very
after
much.
the assisted dying
Thank
section.
you.
So please feel free to depart once
Thank you.
you've completed that. Okay, and I note that we have some members of the public in the gallery today, and I'm delighted to see some observers. And I just wanted to remind everybody to please switch your mobile phones off and maintain silence at all times during the hearing. Thank you. Okay, we have this section on assisted dying to begin with, which Deputy Curtis is going to open with.
Okay, thanks. Minister, please could you provide an update on the estimated timeline for the lodging of the assisted dying legislation, including confirmation that you're still on track for the legislation to be debated in 2025?
I'll start with the end part of that question first, then hand over to Ruth. We're still on track, as I understand it, to meet the November debate, which is what we plan to do. But I think the interim was slightly delayed, but I'll hand over to Ruth, who's got a much more precise.
Yes, so
idea of timing.
you may recall that we were hoping that we would lodge at the end of July, which would allow for a 12-week lodging period for debate in November. We are now estimating, now that we're full on into the law drafting process, we are estimating that we will lodge in early September. So we will still have an extended lodging period, but that extended lodging period will be 9 weeks rather than 12 weeks. We are absolutely anticipating at the moment that the draft law will be debated in November, and there is a discussion ongoing with the Treasury as to whether or not that debate date will be the 11th of November or the 25th of November, because we are looking to ensure debate prior to the government plan.
Okay, thank you. So we asked if you could ensure that the panel, that the assisted dying scrutiny review panel will have sufficient time to review and carry out the appropriate scrutiny, because we did expect it to be around the end of June that we could start working on it. Is there any reason for that delay?
So I mean, and we've always, whenever we've spoken to the assisted dying review panel, we've always been very clear that we can never be definite about the timeframes, because there's a law drafting process over which we have very little control. But where we are at the moment is myself and the officer who's working on this piece of legislation have now seen and commented on the second draft of the assisted dying law. It is back with the law drafting officers, and we are hoping that we will be able to get you a draft of the law by the 2nd of June. That will still be a working draft of the law, because in addition to scrutiny having an opportunity to review it, we obviously need to discuss and consult, particularly with the UK registration bodies, about the impact that the law may have on registered professionals. But we are hoping that you will have it by the 2nd of June.
If I could just add that there's an enormous amount of pressure in Ruth's department, and recruitment is very, very difficult, and we're trying all the time to recruit. Getting skilled policy officers in Ruth's department.
Okay, so in that case, are you confident with the new dates that you will?
I absolutely will never put my head on the line when it comes to law drafting, and I don't think that you would ever have a policy officer who does, because this really is not something over which we have full control. The law drafting officer, who is leading on the drafting of this law, is also working on other legislative projects as well. But what I can assure you with is the bits that are in our control or in the Minister's control We are absolutely doing our best to expedite every single issue as and when it arises.
I appreciate the difficulties about the drafting, but may we have an answer to the question which Deputy Curtis put, which was, will the panel be given sufficient time to review the legislation?
I would absolutely anticipate that if we get it to you, get the draft law in June, then that would be sufficient time to review the draft legislation.
Okay. And can you assure the panel that you and your officers will maintain an open line of communication, ensuring documentation and updates continue to be delivered in a timely manner?
I'm sorry, I didn't catch the first part of that question.
Can you assure the panel that you, Minister, and your officers will maintain an open line of communication to us and so that we have all the documentation?
Yes, absolutely, and I would hope that you understand that we have delivered on that commitment to date and we will continue to do so.
Yeah, okay. Just one more question on this subject. So following the recommendations...
Can I just
Yeah.
build slightly on that? In terms of the scrutiny process, Minister, I wanted just for you to confirm that you understand that the scrutiny process cannot necessarily be truncated if there are delays, and that you will take that into account.
Absolutely.
And in terms of timings, we did do the first review very quickly, and that was in the context of not many other work streams being underway. And in this context, we would need
This is
that
getting a very
usual
high
period of time.
priority in two areas that under a great deal of pressure. What I don't want to do is push people to breaking point and lose them. But we are, I think people are really working to the fullest extent, and this is receiving probably more priority than anything else. So,
Yeah, sure. So,
so
but
I
it's,
can guarantee you that and no more. And as I say, to try and promise the impossible, it's not what we can do.
so you'll continue to factor in that
Continue
that's
to do
period of time for
everything
scrutiny.
we can. I mean, it's important for everybody that this is done in a timely way, and we'll do what we can.
Yeah, that's good. And when we were pressured for time as well when we did that initial review.
Very, yeah.
So just to ask a question about the recommendations from our initial review. You agreed to provide evidence to the Assembly no later than this September on quality and availability of palliative and end-of-life care, and a timeline for after the end of the existing strategy. Also, an appendix including training requirements and about appropriate places, and there was also a couple of other points. So can you tell us when this information will be provided to scrutiny and that it will be public in September as well?
So it will absolutely be available in September, as in accordance with the scrutiny recommendations and the scrutiny findings adopted by the Minister. One of my officers is working on it at the moment. Unfortunately, I don't know when it will be available to share with the scrutiny panel, because she is obviously one officer trying to do two things: progress the development of a piece of legislation at the same time as developing and progressing some of the additional work that is required. So without a doubt, it will be available and it will be lodged in time. Scrutiny will be provided in advance. I just don't know the date of that at this point in time.
Okay, but during September, you think?
I'm hoping it will be before September. I just don't want to commit to that and fail to live up to that commitment.
Yeah. Can you aim to get those pieces of information to us at least a week or two before they're published? Is that possible?
You'll absolutely see them, but you'll absolutely, without a doubt,
Okay.
see them before this. But no doubt about that, you'll see
That's
them before
fair,
they're
thank
published.
you. And Minister, when those pieces of information are published and in the public domain, I'm assuming they're going to be presented as a report to the States Assembly. Is that correct?
I would assume that is the
They'll
case.
Or a series of reports?
They'll be published as appendix to the report and proposition.
Right, okay. Not separately?
No, I'm not sure, because the
Okay.
I'm not sure why. If, I mean, is there a particular reason you were thinking that you would like them to be published separately?
No, that was just my understanding. But
No,
that's-
there will be. The one of the pieces of work is directly related to the end of life and palliative care strategy. That is a separate piece of work, and the officers who are working on that will publish their update separately, because it will be an update to an existing strategy rather than an update that is being driven by the State's Assembly decision making on assisted dying. And the officers who are leading on that will be more than happy to come and brief Scrutiny on the work of the end-of-life care group and the progression with delivery of the objectives within that end-of-life and palliative care strategy.
Okay, thank you.
Minister, I'm just conscious that in the UK there's a debate going through Parliament at the moment. Have you had a chance to reflect at all on the problems that the UK law has encountered and the batting and forth between the Lords and so on, and that whether that it creates the fear that there might be an amount of amendments and so on that might come forward?
I'm aware of what's going on. I just simply hadn't had a chance to look at it in any. It's certainly not in the detail that you're suggesting. But I'm hoping that none of that's going to have any adverse effect on what we're doing, because I think that the job that's been done here is extremely comprehensive. So I'm not anticipating, if that's what you mean, I'm not anticipating problems as a result of that. Here I would hope not.
So it is the case that some of the issues in the amendments to the legislation in England and Wales are about issues that we have already addressed, that we addressed as part of the initial policy development stage that we've gone through over the last 3 years. Some of the amendments are to the UK legislation are what I would describe as novel. They are amendments that relate to issues that we hadn't necessarily anticipated. I am not sure within most of those cases whether or not some of those amendments will be adopted and accepted within the UK legislation because of the nature of them. Sorry, off the top of my head, there is an amendment, the kind of the spirit of which is about the requirement for a separate and independent review of a person's mental health status. The UK legislation doesn't provide for that. Our legislation or proposed legislation does not explicitly provide for that. But we would be confident that the criteria in the assessment process for our criteria ensure that that is considered within the assessment process.
Aren't there mental health professionals in the
UK legislation doesn't have a multidisciplinary team. We had already anticipated that. We had already provided for a multidisciplinary team within our legislation and within the associated budget as well, because we had recognised those particular issues in advance.
Yeah, good.
I mean, in a nutshell, there's been no policy review in the department following the debates that have been taking place in the United Kingdom.
There has not been, at this point in time, a full review of the amendments to the UK legislation. We will be doing that alongside the other work that we are doing around the assisted dying law to ensure that we haven't failed to consider any critical issues.
Great, thank you. Do you want to add any further? No? Okay, thank you so much for joining us, Deputy Curtis. Thank you. Okay, we're going to, and thank you for those answers, we're going to move on to the digital section now.
I wonder if you could start, I mean, perhaps, Minister, I could address it to you first of all. Can you state where you are in respect of the digital health strategy for health going forward? What position have you reached?
Right, I'll just give it a tiny bit of context. One of the first things that struck me when I came into office at the beginning of last year, and it became more and more apparent as time went on, is the fact that we're a long way behind digitally. What we've now, well, one of the things that was apparent was that in previous governments, when everything was centralised and moved into central government, a lot of control was taken away from health. One of the principal things, one of the most damaging things that happened is the digital got taken away from health control, put into central government, and things started to go wrong from there on. So we've gone backwards. We've had a limited budget as well. So one of the things that has happened is the control of IT has gone back into the health system. We've now got Martin, I think he started in October.
I did, yeah.
As a digital health director. And Martin comes, as he'll explain, with a great deal of experience. Gave us an opportunity to start looking at things very differently. Martin and I had a conversation, and I said, basically, Martin, can you sort of work out where we need to be? I'm sure Martin would have done this in any event, but he came back and said, look, we're a long way back, and this is what we need to do. I'm not going to steal any of Martin's thunder. I'll let him explain that. We then swiftly moved to set up a digital group or board. It's not formally a board. It's a group, and it basically the key members of that group reflect the members that we're hoping will be on the partnership board. They come from various areas. You've got the charitable sector, GPs, Digital Jersey, Jason, who's head of digital right the way through the whole system. So every component there, and we've got a lady, Emma Martins, on data management. So that's now set up. I think we've had 4 meetings, and we've got some quite big objectives over the next 5 years, and that's probably enough for me to say, and you're probably best to move on.
Can you clarify then that this is essentially a new stream of work?
Well, there's there's 2 streams. There's an existing stream that's happening with that Martin's doing with the funds that are available to him, and there's a recognition that if we're going to do the job properly, we need to be a lot more ambitious than that. So there's a stream of work developing where we want to go, and the day work that Martin's actually carrying out to make the best of the money that he's got.
Okay, so we should probably, can we focus on this new piece of work, if you
Right,
like?
I'm very happy for that, yeah.
To say what have you identified as the need?
I'll hand straight over to Martin.
Can I just ask a follow-up question? You said Martin's using the money that he's got. What has he got currently? Or what has this project got currently?
Okay, so I'll start in terms of the money that we've currently got. So we've made investments in the hospital and improving how the hospital operates digitally, and that programme of work has been going in place for a couple of years now. We're hoping that the majority of the work will come towards an end at the end of this year. At the start of that particular programme, we used an organisation called HIMSS, which is an internationally recognised benchmarking organisation, independent, who undertook a digital maturity assessment of the hospital and assessed it at 1. By the end of this year, we're hoping to achieve level 6, which was part of the original plan. That organisation also looked at how we are performing as a system, i.e. the flow of information that goes from primary care to secondary to community, for off-island escalation in tertiary. So how that information is flowed around and how that supports continuity of care. HIMSS assessed Jersey at things like health inequalities, which we know is a strong motivator. Value for money as well, in the context of if we don't make this investment, what does it look like for the island economy with poor outcomes and inefficient workforce. And then the final bit is around workforce experience and attracting and retaining colleagues who work as health and care professionals to deliver their services. So armed with the backdrop of that and talking to islanders, health and care professionals and a variety of stakeholders, it became apparent that people's experiences is particularly poor. And we're also recognise, and through our internal systems, that we've got a number of incidents which relate to patient concerns where data has been fragmented between different service providers. So we've built a 5-step plan, which we have taken through as an outline business case and submitted to Treasury in terms of high-level numbers. And now we're taking that through the process of getting that approved and looking to seek funds in order to make that happen.
So what we're looking at here is a major investment in digital health, basically.
It is, yeah.
Can you put, Minister, any figures at all on this?
Yep, over a 5-year period, it's an additional, it's an additional 70, isn't it? Or is it
It's additional 70 million.
Yeah,
I think the thing to think about is at the moment we've got an investment of 0.6% of revenue in terms of digital transformation. Industry benchmarks suggest that should be around between 8 and 12%. The number that we're after is 5%. So we're doing that, and the reason why we're able to look at that number is because we're using existing tools and technology. So we're not going to reinvent the wheel. This is very much we're going to take bits of technologies that we know to work in other jurisdictions and put them together in an efficient and effective manner.
Thank you. And what has been spent so far on this?
Talking about the normal budget.
So the amount that's been spent on it is purely from internal time. So it's the team's time in putting together the plan. We haven't spent any money on the new programme to work at all.
Okay, could you reflect on that and get a figure to us on, as part of your budget, what has been spent on this area so far?
All of the figures that have been spent so far are detailed in the government plan, are they? Not last year.
Yeah.
All those details, yeah.
Yeah, so, we would just like to know what, has the full amount been spent? Are you going to spend the full amount? Is there going to be an overspend on this project?
No, certainly I think that money will be spent, but I don't think we're planning to overspend against the existing budget either.
No, so we're actually, in terms of the existing budget, we are on plan.
Okay.
And we're not tracking any major risks to believe that we will be off plan either in revenue or capital.
Sorry, Tom.
No, it's just the current plan is very unambitious. And as you know from previous discussions, we start from a long way back.
So you're talking about going from 0.6% to 5% of spending on digital, which is an additional expense. The health budget, as we know, is already under massive pressure.
Yeah.
Where's the money going to come from?
It's all part of Project Breakwater. That's being worked on at the moment, as you know. It's delayed, which you know as well, but I think that's going to be coming up fairly soon, and that's all explained in there. And from my point of view, I'd be quite happy spending existing money for that, because knowing the work that's been done, if we fail to do that, our costs are going to run up exponentially.
When you say existing money, you mean reserves?
If it needs to be reserves, as I say, that's something the Treasury are looking after. I'm sort of warned against going around talking about spending reserve money, which is fine, but I mean, it's just an opinion on my part. But we'll have a clear plan when the time comes to release the project.
It's talked about a 5-year plan to get to 5%, but it is recurring after that, isn't it? We're not talking about suddenly dropping back down.
No, that's correct. But I think if we start to budget from that, I think what you're going to find from that, you're either going to do one of two things. You're going to see a lot of savings from efficiency. Whilst you're getting those savings from efficiency, your costs are going up as well. So you've got two graphs to look at. One is how those savings look against your rate of increase anyway, and the other is what your rate of increase would look like if you don't invest the money. And from everything that I've seen, it strikes me that if you don't, there's a cost for doing this, and we know what that is. It's 5% of the budget, and there's a cost for not doing it. And I'm hoping that when all the facts come out, it'll be very, very clear that the cost of not doing it is going to be a lot greater in the long term.
Thank you. I wonder if I could follow that by asking, the Treasury Minister has quite recently told Corporate Services that she doesn't expect there to be any growth bids this year in the government plan. Have you had any indications from Treasury that this will be allowed through the system, as it were? And do you expect the bids for money to be capital or revenue or both? How do you see this going through the process?
When you talk about growth bids, there are two separate things. this piece of work sits alongside, well, I say it's part of Project Breakwater, which is, in my book, deemed to be separate from the day-to-day budgeting. That's an investment for the island that we have to do over and above our normal spend over a 5-year period. As I say, it'll come to the Assembly and people look at it and they can laugh it out of the Assembly or vote for it. But that's not meant to be affecting the day-to-day budgeting. So you've got your health budget, but this spend for the 5 years is a piece of project work to be funded differently. And there are 2 health components to this work, apart from the infrastructural side. One is digital, the other is turning the health system from a reactive to a proactive system. And that's about preventative healthcare.
And so do you expect that to come through as part of the budget, but as a separate part of it, a new part we've not seen before?
But as a separately funded, yeah, not part of day-to-day funding.
But it will be considered as part of the budget.
It'll be considered at that time, yeah. Yeah, and there are issues about health funding, and as you know, I'm going to be doing presentation to first to Com, then to the Assembly members, a fully detailed 2-hour presentation on where we are with health, because we've got some specific difficulties there that people need to understand.
I'm just trying to understand the funding. So you're saying it's over and above, and it's what?
Cashable savings as a result of making this investment. So things like off-island escalations, the retirement of legacy systems, reduction in admin. So there are savings to be had directly in terms of the quantifiable benefits as well as the unquantifiable benefits.
Mr. Carpenter said that they were going to be you were going to be using tried and tested technology, I
Yes.
think, and not going off on a new venture. But the world is going to move on in 5 years,
Yep.
so presumably the scheme of things will allow for some reaction to be had to changes in technology.
Absolutely. And the architecture that we're adopting enables that. And a principle of that is separating out the data away from the applications. What tends to happen is when organisations buy systems, the data almost becomes ransomware within that application, and it's quite difficult to get out. So the approach that we're adopting, which is the same approach that jurisdictions such as Estonia and Catalonia have used, is using an open data framework to store islanders' health data. And the ambition is that that data exists over the lifetime of that individual. There is no need to change the structure of that data. The thing that will change is how people access and view that data. And because it's just the access and view, we should be able to implement that relatively quickly, but also at lower cost over time. So we won't be in a cycle of constant replacement, I say constant replacement every 10, 12 years or so.
Thank you.
Probably safe
Minister.
to say that we wouldn't be restricted to using some state-of-the-art technology
No, not
throughout
at
the
all.
whole course of this process. It doesn't mean that we're using bog standard stuff throughout everything, and we've got a closed mind to using state-of-the-art stuff that comes on the market. That's something that can be bolted in. Yeah.
Thank you. Minister, hundreds of millions have been spent
Yeah.
in the past on digital improvements that haven't been completed. Can you advise us how this project is going to be different and how confident the public can be that this will deliver?
I think they can be a lot more confident because we've got all the required people around the table with a very clear view of what needs to be done. We've got a highly experienced individual in Martin leading the operational side. So I don't think if somebody can tell me from anywhere how we can do better than that, I'm all ears. But we genuinely want this to work, and if anybody's got some further ideas they can offer us, that's fine. But I think that the setup we've got, the people that we've got involved, covers all areas of health.
And what have you learned from those previous projects that you are doing differently?
To be honest with you, I've not spent a lot of time looking at disasters and what's gone wrong. My entire time, I'm afraid, has been spent on looking at the rather complicated muddle that we're in and trying to see a way clear.
Okay, any further? No? Okay, thank you. Thank you for those questions. If you do need to leave, please feel free
you
to
very
do
much.
so. We're
Thank
going
you.
to move on. Thank you very much. Okay, we're going to ask some questions about the partnership board process. Thank you. So, Minister, we understand that you have produced a draft terms of reference for the partnership board. Can you advise what organisations and individuals have been included in your consultation on these?
Oh, crumbs, I think, how many consultations have we done?
So
Several dozen.
in terms of the draft terms of reference, the draft terms of reference were circulated to all nursing homes, all care homes, all dentists, all doctors in Jersey, to third sector organisations that are providers of health and social care, and I think one other that I'm just not recalling off the top of my head. So we circulated the draft terms of reference, pharmacists.
Yes.
We circulated the draft terms of reference. We invited people to send us comments by email. We also arranged a series of evening meetings where people could just come and talk to the Minister and I about any comments or queries that they may have on the terms of reference. Those meetings were, some of them were well attended, some of them were very poorly attended. On the back of that feedback, we have done two things. We have produced a feedback report setting out the key themes of the feedback. A draft of that feedback report is with the Minister, just waiting an opportunity for him to review it, and then it will be published, and I would imagine that will happen next week, if not sometime this week. And we have also updated the terms of reference, the draft that we circulated, to reflect some of the key areas of the feedback that we received. The Minister's Office is setting up briefing meetings with PAC, PPC and Health Scrutiny to talk about those terms of reference in more detail in accordance with the requirements of PE 170 2010.
Yes, PAC, I think we have a meeting with them, don't we?
Yes.
Yeah, thank you for that. Minister, the feedback report, would you consider, when that's presented, doing a statement to the States Assembly so that questions can be put to you on that?
I'm quite happy to do that. There's no reason why not.
Great, thank you. How much will the board cost to set up and run? In fact, how much has been spent so far, and what's the total budget?
I don't think we've spent anything outside of standard budget. Using,
Within your budget, how much of your budget have you spent
I
on
don't
it?
think we've actually costed it out. It's
just
just,
my
it's just
time.
daytime. Yeah.
The board will cost money to set up because it will have paid people on it, it will need resource and so on. So how much will it cost to actually run?
So we've done the budget will be set out in the terms of reference when they are lodged to the States Assembly, and the anticipated annual budget is £70,000 a year. £70,000 a year comes within the underspend of the existing advisory board. So therefore, in the report and proposition, the Minister will not be requesting new or additional monies. It will be within the current governance budget that HCJ currently has.
Okay, and what do the advisory board think about that?
I think the advisory board are fully supportive
Yeah, they are.
of what we're doing, and I'm quite minded. In the advisory board's terms of reference, it would allow them to advise on whole system work rather than just HCJ. And I think they would quite like the opportunity to advise on the whole system because they're quite excited by it. I think they see this as being an opportunity for Jersey to sort of have something quite bespoke. And given the quality of the people on that board, I'd be very happy to see them advising across the broader health spectrum.
Yeah, Minister, have you given thought to what happens if there's a disagreement between the Minister and the board?
Not specifically, because you've got potential for disagreements between the Minister and various component parts of the organisation at the moment, and HCJ being one of them. So that's something that.
I guess my point is that the board is set up as a thing that is intended to resolve issues, make sure that there's consistent, coherent thinking and so on.
Yeah.
But it's all in the detail, and unless there are processes in place for dealing with this and clear lines of responsibility, where decision-making power lies, and where that question of what will you do if the board advises you to do something you don't want to do? What happens?
Well, I see these things are sort of governed in law, or they're not. The minister has powers to do things, and the minister has things that he or she cannot do. And I think that would be the overall governing principle, is that you be guided by the framework that's in place at the moment. Because nothing's likely to come up that would be any different to it coming up with or without the board. So whatever the anomaly is, it would have to be dealt with.
There would be a difference because the board would have more authority than it would do if you were just, say, approached by the GPs and told to do something. It would now be a coherent, consistent board position, and that might carry a lot of weight compared to the minister's.
Well, that would put more pressure on the minister to decide whether he wanted to go against a cohesive board of people that are handling the health system. So you're right, the dynamics change slightly, but it doesn't make it impossible. And
It's a non-statutory board, isn't it?
non-statutory
So
board.
it will have no
certainly in this case.
legal authority.
No, that's
And
right.
the authority will remain with the minister.
With the minister, that's right.
And I wonder if I might just help
Yeah.
a bit in terms of reference. So it is a non-statutory board. It works by making recommendations to the minister, and the terms of reference clearly set out that it's the minister's right to adopt or reject those recommendations as it wishes. However, the terms of reference do require that when the minister is rejecting a recommendation of the board, the minister must in writing explain and set out the reasons for his rejection of the recommendation. So there's complete transparency as to the minister's decision within that.
That's helpful. And would that be public?
I can't recall off the top of my head whether or not I've provided for that in the terms of reference, but we could certainly give thought to that, yes.
Thank you.
You could rest assured if it's something of major importance, it would probably find its way into the public domain, and we have to accept that some of these things would become political. So whoever the minister happens to be has got to have quite a tricky job to make sure that if they're going to be overruling a combined team of professionals, that they'd have to know what they're doing, and they'd have to be very sure of their ground, because they wouldn't survive long politically if they didn't. So, like I say, some of the existing dynamics would still work in that scenario.
Thank you. How will... Did you want to...
No, I was going to say the political axe can always fall upon the minister, can't it?
Absolutely right. And all of these things will play out in public, and so people have to be very careful about what they're doing.
Thank you. How will the effectiveness of the board be monitored over time?
I personally haven't given a huge amount of thought to monitoring it, because it strikes me as, perhaps I shouldn't say, as with basic common sense, that if you have a formal structure for people that are working together anyway to come together and make collaborative decisions, you're going to get better outcomes than having things as they are at the moment, which I consider in some areas to be fairly random. I can give you a number of examples of areas where a lot of time has been wasted because there's no formality around the process. So I don't know, Ruth. You can probably elaborate a little bit better.
The terms of reference for the board provide for a number of things. So first of all, they provide that there must be an annual review of the board and the board's performance and its effectiveness. And within that £70,000 budget, we have allowed some money for that review to be undertaken independently rather than a self-review process, which is very common amongst boards. But because of the nature of this board, we feel that then it should probably benefit from some independence. The terms of reference also require the board to produce an annual work plan, and within that annual work plan there will be key performance indicators or statements of intended impact, because of course it's working through recommendations, so it can't necessarily put hard and fast key performance indicators against it, and the annual review process will need to report against that.
Okay, and will those KPIs be SMART goals?
To the extent that you can do when it is a board that operates through making recommendations to the minister.
Okay.
And I think that, that's one of the things that we have to accept, is that as part of a whole system improvement and governance structure, neither the partnership board nor the existing advisory board are statutory. So ultimately, their abilities to deliver and create change hinge upon the minister.
I would, I take your point, Minister, and there's not a single minister who's reorganised health who hasn't wanted to improve it. And the reason why you have monitoring and so on is to make sure that it actually does. I mean, the UK has just dismantled its, it was in the process of dismantling a major health reorganisation that was supposed to deliver tremendous improvements. So I think that, do you accept the need to have monitoring and...
I accept that you do all the monitoring that you possibly can, but what I'm saying, you can have all the KPIs you like, but at the end of the day, the proof of the pudding here will definitely be in the eating. And I think it's really the patient experience that's going to tell you whether it's working or not.
And just to add with regard to the UK, because it might be helpful to understand some of the context of this, the UK obviously are dismantling NHS England. They are retaining the integrated partnership structures that they've created in the UK, albeit they are reducing the spending, and they are reducing the spending so that the integrated partnership structures get back to points of first principle. And the points of first principle are about collaborative working at a local level, which of course Jersey is, across different providers, to resolve problems and conflicts with integrated care and appropriate decision making about priority services, which is absolutely plum territory for the terms of reference for this board.
Thank you.
What the NHS are dismantling isn't what we put together. is it?
No, my point
No,
wasn't
they're
about whether...
going
it was
back
about the
to-
fact that everybody sets out with good intentions and they don't always do
Well,
that.
Okay.
I was going to say the road to hell is paved with them, but never mind.
Thank you. After initial appointments have been made and the board is operational, how will you ensure that appointees do not become entrenched in the roles and that fresh candidates will have the opportunity to join the board?
To an extent, certain participants are there by virtue of their role. Anybody that's on the state's payroll, that's a statutory position. What you must be referring to is the external providers. And we've made it clear all the way along that we want the external providers, the representatives, to be, I think it's very, very important that they are elected by their representative sectors. I've said all along that for the state to appoint somebody from the GPs or to appoint somebody from the charitable sector over the heads of the people in that sector would be entirely wrong. It would do away with all the basic principles that we're working to. So the people who represent those sectors will be selected by the sectors themselves.
Okay. Will a public register of interests be maintained for the board members?
I should imagine it would have to be, wouldn't it?
There will be a all members, when they're appointed to the board, will need to declare their conflicts of interest, and also at each board meeting, if there is an item being considered, they will need to have to declare their interest if they have an interest relating to that item, and the chair will then need to determine whether or not they should be recused. One of the things that we have done is we have developed a draft person specification, both for the community partners on the board and also for the chair of the board. We haven't circulated those because obviously they're very embedded into the final terms of reference. But within that, we have done some quite hard thinking about whether or not, or the extent to which people should be excluded from sitting on the board in the first instance, as a result of the interests that they may have.
What criteria would there be around whether somebody would be excluded or not? Like, what's the threshold for that
I
exclusion?
think that would vary from individual circumstance to circumstance, wouldn't it?
So what we've done, and this is one of the areas that there was quite a lot of discussion about when we went out to consultation with external stakeholders. There is a reality that many of the external providers who will sit on the board are private providers of services. They are GPs who make money. They are care home providers who make money. So we initially went out with the proposal that you should not be able to sit on the board as a community partner if you have a financial interest. But of course, and rightly so, and understandably so, those external providers pointed out to us that excludes virtually everybody, and not just current providers, but also retired providers, because they often retain a financial stake within the companies that they worked in as with partnership structures. So what the terms of reference provide is that a person is not excluded from membership if they have a financial interest, but the minister must be advised of that financial interest prior to the appointment and have full understanding of it. So the minister can make a determination in discussion with the chair as to whether or not they think the extent of that financial interest precludes them from being able to act independently or being perceived to act independently.
So the
within
minister
board.
has the final decision
So
on
the
that?
minister in consultation with the chair of the board.
Sure, okay.
Sorry, Philip. The important thing, Minister, is it not, is to get the right people round the table.
Always.
It's always the most important
Absolutely.
thing.
Yeah.
And one mustn't be constrained too much by process.
No, you're absolutely
And
right.
so my question to you is, will you as Minister be taking a personal interest in the appointment of the board so as to ensure that the right people are round the table?
Well, I, to the greatest extent that I can, without overstepping
Of
the
course.
mark, and as I say, with the various sector representatives, we've made it plain we're going to sort of provide guidance as to the sort of person that we think is appropriate. But ultimately, if you're a GP, you want those GPs to have made that decision. You make it clear to the GPs what sort of person that you think you'd recommend. The exception, I think, is the chair, and that would go to the Appointments Commission, and that's something over which I've got no. That having said that, and I don't mind saying this, I'm very, very keen that all further appointments, senior appointments within health, contain more than one of our NEDs, of our non-executive advisory board directors, because they're people of great quality, great experience, and I think that appointments will be of better quality if people like them with the experience they've got play a part in the appointments. So that's something that I'm going to be taking forward.
Adding them to the JAC for those jobs?
Yes, for those particular jobs, making sure that we have, I would say, a minimum of 2, because my experience of them is that they've got very good judgment. And if, as I say, I can't interfere with that through the Appointments Commission, but what I can do is make recommendations as to who best might sit on that commission.
Very quickly, the process of creating the board effectively internalises conflicts that already happen but elsewhere.
That's right.
So, GPs want more money, so do dentists, so do, whatever.
Everybody.
So what processes do you have in place on the board to resolve those conflicts?
Maybe I've got this wrong and you might be able to pull me up here with. I think some of that stuff has to be just dealt with in the same way as a board of directors would if they're running a company. It's decisions that need to be taken.
One of the things that, as I mentioned to you, you've done a draft role specification for the chair, and one of the things that we are really emphasising in that role specification is one of the key duties of the chair, and therefore the attributes and experience that they will need is to be able to work with board partners where there is conflict on that board, to be able to drive forward consensus. We have to accept, however, that in in probably quite a few cases, that won't be possible. But the advantage of the board is it allows those conflicts and those tensions to be recognised across the whole board, rather than disparate pockets of conflict all over the place with no forum for trying to resolve.
And I think the structure itself takes a lot of those tensions away, because there's going to be, I would envisage there being a much, much better collective understanding of the various problems. What I have found is everything working in silos today, people get very entrenched, they get very angry. If decisions are made by one party that affect another, then that causes a lot of animosity, and that wastes a lot of time. And I've seen that cause a lot of bitterness, and it stops things from progressing. So, and everybody's job description will require them to focus on good patient care and a good patient journey through the whole system.
Can we move on?
Yes, I'm just doing a time check. We have 35 minutes left, so panel, we're going to need to speed up through the next section.
Medicinal cannabis.
Yep.
Could I start, Minister, by asking, do you have concerns regarding the accessibility of medicinal cannabis in the island?
I have to confess I have some concerns about the extent of cannabis consumption on the island, albeit that I believe that everything that's being done is being done in accordance with the regulations that we've got at the moment.
The Health Advisory Board said in March there is a notable increase in the use of medicinal cannabis, particularly in private prescriptions, which impacts the quality of care in other departments, especially mental health. Is that a polite way of saying that we're creating a mental health crisis out of cannabis over
Well, I think
prescription?
what we have to accept, and I'm very happy to hand over to Andy, but I'll just make this as a political point. I think what happened in Jersey is that we were swift to legalise medical cannabis without making sure that we've done all the homework to regulate it properly. And I think that we're possibly suffering as a consequence, but I've probably said enough. Over to you, Andy.
Yes, is the answer. I'm not sure we'd go as far as to say a mental health crisis, but certainly we're seeing a significant increase in people that are requiring admission acutely, for example, to Orchard Ward, who have been using large amounts of prescribed cannabis prior to that admission. There are still a number of concerns shared both within health services and within primary care about the prescribing of cannabis to people with known serious mental illness, and both the volume of cannabis that's being prescribed, but also some of the nature of the prescribing creates a significant concern for us.
What actions are being taken given that finding from the Health Advisory Board?
So there are a number of pieces of work in train. So Peter perhaps could talk some more about this. We've certainly got a group where we've been meeting with people from Guernsey, looking at issues around prescribing of cannabis, how that's working, some of the concerns in relation to mental health services there as well. We've had some conversation with some of the cannabis prescribers about these concerns. There's a piece of work that's underway to allow prescribers of medicinal cannabis to access primary care and health records, because sometimes, of course, people may go and be seen by a prescriber for medicinal cannabis and not declare that they have a serious mental illness. But access to the primary care record should help with that. And then there's an ongoing piece about potential regulation by the Jersey Care Commission, because, of course, the biggest challenge that I have is that these services are unregulated. So actually the only default position left to me is to think about individual prescribers and their practice, and there's nothing else that I can do in relation to this.
So, and just in addition to that, we're currently working on an advertising order which will prohibit the advertising of prescribed medicines. So when you arrive at Jersey Airport at the moment, you see big adverts. Those adverts for medicinal cannabis, once the advertising order is made, will no longer be legal.
Do you worry, Minister, that there's a profit incentive here for people to effectively cut corners?
The straight answer to that is yes. Well, I think there's a big profit incentive somewhere down the line, but
Would you favour regulation to bring tighter control?
I think the plan is to introduce regulation. As I say, it's been done in retrospect, which is a shame, but that's moving as quickly as we can.
As soon as we have addressed some of the other legislative policy priorities, we will be moving to develop the regulations that allow for the Jersey Care Commission to have oversight of cannabis prescribing clinics in Jersey.
I know it's been mentioned, but I think patient records being available to all the prescribers is going to make quite a difference, because as I understand it at the moment, nobody's got any oversight of, I think I'm correct in saying that if somebody wants to be prescribed cannabis, they can go to a range of outlets at the moment without anybody knowing what anybody else has prescribed. And once the patient records are all linked up, then there should be some oversight of that, which I think could bring about a fairly substantial change.
Does that mean that some people are being double prescribed without others knowing about
Making
it?
assumptions, what I would say is that I think that's possible to do at this point in time.
We did an audit, not of cannabis prescribing, of cannabis dispensing, which is a slightly different thing, 2 years ago. And the information provided that underpinned that audit suggested that there may be some patients who are accessing medicinal cannabis through more than one prescriber. I say all this with caution because the way in which the data is collected it is not always necessarily, we don't have unique identifying numbers for those patients, so we are making some assumptions through name records that is the case. But we are aware and concerned that there is a possibility that may be occurring.
And we certainly know from anecdotal evidence from people that use services including the Alcohol and Drug Service, there's quite a lot of sale of medicinal cannabis as well. So it's sold on for other purposes.
So we've created a black market in prescription drugs.
So there's no
Legal
doubt.
market,
Yeah,
we've
legal.
replaced.
Yeah. So you know, very clearly, my perspective is one around the prescribing of medicinal cannabis for people with serious mental illness who shouldn't be prescribed it. For some people, the prescribing of medicinal cannabis is an entirely legitimate thing, but the volume of prescribing here, the number of people that are being prescribed for, and some of the prescribing gives rise to significant concern.
Can you explain what kind of impact it is having in terms of the mental health services? Like, how does it manifest?
So some people with psychotic illness, for example, are becoming unwell more quickly, perhaps more unwell, because they're utilising cannabis, perhaps not utilising prescribed medicines. And there's really, really good evidence base now around particularly young people and the use of cannabis when brains are developing, that high volumes of cannabis can significantly lead to psychotic symptoms. So we're seeing people that are struggling anyway, who are just struggling more because of the prescribing of medicinal cannabis.
Do public health have a role in this?
Yes, so we're very involved in the work, and I can't really add much content, but I work very closely with both mental health services and within the health policy area.
But in terms of educating people, given that the prescribers can't access the records to establish whether people have a serious mental health problem, could we educate the public about those risks?
So there's an ongoing process about substance use, and we have various campaigns about particular areas. I think my immediate reaction is the education here needs to go to the practitioners, actually, because the number of people who are particularly at risk here is relatively few if we talk about the more severe events. And I think it's very important that we educate people to understand the risks of prescribing cannabis medicines to people who are potentially going to be harmed by them.
We did, however, really quite recently produce some additional guidance, which is in the public domain, on medicinal cannabis and use of medicinal cannabis. And we can forward that to the panel if that's helpful.
I think I'm right in saying, I hope I'm not imagining this, but I think I had a conversation with somebody this morning who said that the patient records should be available within 10 to 12 weeks.
Oh, okay.
I'm hopeful, and if somebody can confirm that, are you aware of that?
We are hoping
Yeah.
that it will be available quite soon. There are some contractual issues and some financial issues that we need to resolve that relate to the contract, which will allow the cannabis clinics to access EMIS. We are busy working on that at the moment, and it is a matter of weeks.
Okay.
A lot of pressure being put there to make sure.
Reception services were working, and that the increase in support offered to young people would be considered. Can we ask for an update on where you're at with
Well,
that?
certainly we're already providing free contraception for everyone under 18 and under 23 at the Le Bar Centre, and for students under 21.
I think there was a wider piece of work around contraception services.
Yes, we are something that we are working on, but it's still work in progress.
Do we know?
Because I think it could be a better service, because I still don't think that people are quite aware of what is available and where it is available. But it's something I am working on, but it's just going to take me a bit longer.
What timeline are you working towards?
Well,
there?
definitely before the end of this term.
So, unfortunately, the officer who is leading on this work is on long-term sick, and we are not, at this point in time, we don't know when their return date will be, and it is hinged on us having the available resources to do it.
Okay. But I'm very happy to also do what I can. Yeah. But I know it's not my, I can't tread on officers' toes.
Yeah. And in that scenario, as leading a policy team, which we know is very tight and overstretched already as it is, with a recruitment
freeze in place, what do you do? How do you just have to not do the work?
So we actually have permission to, despite the recruitment freeze, to go out and recruit, and I am interviewing a number of people later this week. So I am hoping, because we do have a particular pinch point around health policy at the moment, I am hoping that we might be able to resolve that pinch point in the near future.
Thank you, that's good to hear.
Can I ask a related question? Has any other policy work been delayed, for example, the termination of pregnancy work, because of those shortages?
No, where there is a state's decision behind a piece of work, we always prioritise that. So in terms of the health policy team, the 3 pieces of work that we are prioritising above others are termination of pregnancy, assisted dying, and the proposition on options relating to decriminalisation and regulation of recreational cannabis, because those have hard assembly decisions behind them.
But I have signed a ministerial decision for the termination of pregnancy.
Great.
I did that.
And I think just following on from that, at the public hearing, you also committed to investigating whether the services providing termination of pregnancies were trauma-informed. Is that something you can update us on now, or is it going to feed into that work?
It'll probably feed in, but there is definitely a counsellor available at the clinic at all times, at the termination clinic.
And is that...
it's a free counselling service.
Is there a waiting list to see that person, or
No,
can they be accessed?
I think it's accessed immediately.
And one of the things that the draft law will do, presuming it goes ahead, is it will place an explicit duty on the minister to make sure that there is sufficient counselling available with regard to termination, and that isn't just for women who have terminations, but that would also be available to their partners as well. And that will be regardless of whether or not it is just the minister who it remains as the sole provider of termination services in Jersey, or there are other providers of termination services in future.
And can I just say we want to support, because I think for women making this decision, it's a really, really delicate and difficult decision for them to make. And I think we have to give them all the support that we can.
Can I follow up on the counselling? So there is a specific approach to counselling which is trauma-informed. So could you commit to checking that counselling service has that specific expertise? Thank you.
I think there's also a lot of help at Dewberry House.
Yes, and I wanted to ask as well, in terms of the counselling service, will that counsellor be trained to spot domestic abuse?
I will check, but I would have thought so, because that we've committed to making sure that health professionals are very aware of that.
Yeah, okay, if you could follow up and let us know about that, thank you.
Yeah.
Okay, thank you. We have some questions on men's health following the women's health questions. We're going to start with the suicide prevention strategy, which of course covers islanders of all genders. Minister, in the foreword to this strategy, you stated that you are committed to ensuring that the resources are in place to make this strategy a reality. Can you outline what resources are currently in place and what resources are due to be put in place, please?
I'm going to hand over to Andy because he's got more detail than I have. But we are at the moment hidebound by the resources that we have. There isn't anything extra. So
thank you. And just another time check, we have just over 20 minutes, so as succinct as possible, please.
There's a multi-agency suicide prevention oversight group that's chaired jointly by Peter Bradley and myself. That includes representatives from health, social care, community services, etc., the police, the ambulance service. There's a lot of resource already in the system that works around suicide prevention. So, for example, I have a consultant nurse in mental health services whose role is predominantly around post-venture, but also suicide prevention work and training. So we're thinking about how we utilise those resources in a different way. The group has met on a couple of occasions since the strategy was published. We've developed an action plan for this year in terms of implementation. The big focus of that action plan initially is a campaign around men, relevant to your question. We've clear evidence now that men are not seeking help at the point at which they're experiencing suicidal thoughts or hopelessness. So there's a campaign that's currently being drafted to help address that. So in the end, we're really thinking about how can we best use resource. So the Samaritans, for example, are part of this work and are really keen to do some additional stuff on top of the work that they do currently to help deliver the strategy.
Okay, and Minister, could you outline, or Mr. Wade, the work around creating cultural change and reducing stigma around men accessing help with their mental health?
So that's the piece of work that's currently being done. We have to be slightly careful. The evidence base is that if you seek to do a suicide prevention intervention in a community and you do it poorly, you increase the rate of suicide, you don't decrease it. Peter and his team have been immensely helpful in providing evidence-based interventions for us to help us shape the type of work that we're going to do. But essentially, you're absolutely right, the issue is one of stigma. And it is one of making sure we review all cases of actual or assumed suicide, and we're clear that in the most recent cases within the last 18 months, half of the folk made no attempt at all that was known to seek help. Clearly, we don't know whether they rang the Samaritans, for example, but certainly in terms of accessing statutory or charitable services, they appear not to have done so. So that feels like an absolute priority for us, and particularly around men, middle-aged men.
Thank you, and it's great to hear that this is being addressed. What other risk factors are there linked to suicide?
So the strategy sets out a whole series. So young women are the other area of concern. One of the suicide prevention strategy talks about the interventions that we put into schools, but also talks about social media, because we know that's significant. Jersey is part of the National Confidential Inquiry into Self-Harm and Suicide, which is a research project that runs in England from the University of Manchester, where when it's believed that someone has taken their own life, a data set is collected in relation to them, the support they're receiving, access to services, all of that. We provide data into that report, and they report each year. They were talking in their most recent report about social media being a key issue, poverty, unsurprisingly, gender and sexuality being key issues. So there are things changed. The demographics go up and down, but there are some key themes across a number of years now that cause us to focus on those.
Thank you. And Minister, given that the strategy, and we've just heard the evidence of links between suicide and the social determinants of health, such as poverty, housing, employment, etc., and some diversity-linked issues, how are you planning on working with the wider team in terms of the Council of Ministers to tackle this?
Well, we're on the point of setting up, if you like, a health-associated ministerial team, which will include, obviously, health ministerial team, social security, housing, children and education. Those five ministers to start working. We haven't set that up yet, but the intention is to do that, so that we can start making a collective approach to the whole situation.
Okay, and in terms of young women and probably young people generally, could I ask, Peter, what's the evidence in terms of you mentioned social media was a factor. Is that the biggest impact on that group, or what other kind of impacts are there?
I think it's very difficult to establish what the biggest impact is. It's much easier to talk about trends. So as has just been described, there is a particular issue about self-harm, which is more prevalent in girls and boys. But also there's an awful loss of evidence now to suggest that levels of anxiety and things that would precede any event of self-harm is becoming more common amongst younger people. Social media and the use of digital technology is often quoted, but there are other factors in people's lives that may promote those events. I think it is an issue that is unfortunately one that is more worrying at the moment and an area of concern for public health.
Thank you. And Minister, given the negative health impacts of social media and some technologies on children, what are your views on how we can mitigate that in schools?
I think
From a health point of view.
I'm treading on some fairly delicate political territory here, am I not? I'd like to see the complete removal of all phones from school. That's a personal view. I don't see there's a place for phones in schools.
Because of the health reasons, the health
Absolutely
impacts.
right. Yeah.
Okay.
I don't mind saying that.
And is that a view that you have shared with your colleagues on the Council of Ministers?
Yeah, I think that's fairly widely known. Yeah.
Okay. Okay. And do you see a way forward in achieving your
Only just
views?
a continual conversation with people.
Okay. Okay. Thank you.
Yeah.
Yes. Okay. Thank you. Would you like to move on to?
Prostate cancer, can we move to prostate cancer? Can we move to talk about that? There have been a number of calls, Minister, for an island-wide screening programme for prostate cancer, and I wondered if you could tell the panel whether anything is happening in that respect.
Okay, I think that's a little bit more complicated than it first seems. I'm going to ask Peter to comment on that.
So the prostate cancer screening isn't currently advised in the British Isles, but there is a test that people who are concerned about prostate cancer can access, and that is the same in New Jersey. That is available through primary care. There are pros and cons with the test. It's not the most accurate of tests, and you can get a number of false positive results, which mean that people may go on to have treatment that is unnecessary. However, this is an area that's been heavily investigated at the moment, and there's a particularly big clinical trial that's ongoing. It may be wise to wait for the results of that trial, which will definitely say whether a full population screening should be implemented. So the difference there is, on the one hand, you're offering a test to people who have a concern and they wish to access that test through their doctor, and on the other hand, in the screening program, you're actually proactively going out to people who consider themselves to be healthy and really actively encouraging them to come forward. So at the moment, the position we have is that we are waiting for the results of that trial and seeing what further developments might happen in the rest of the United Kingdom.
So no research is being carried out in Jersey, I take it?
No, it wouldn't really be possible to do that. So the numbers of people that you need to be involved in these trials are considerable. I do believe, I'll have to correct that, at one stage we did actually look to see whether Jersey residents would be able to join that bigger trial, but unfortunately it wasn't possible.
I mean, if there are any indicators of prostate cancer, I take it that any patient can ask for a PSA test?
Yes, that is correct. And normally after 50 as well, if a person that goes to their GP, many of the general practices on the island offer the test.
Right. It's not the policy of the department to encourage men, I should say, to seek advice on whether or not they should be taking a test?
No, it's actually quite a delicate balance. There's a recognition that people who, particularly if they have a family history or they have major concerns, may benefit from the test, but there is also a possibility that that wouldn't be the right decision for them. So at the moment, we are waiting for further developments from the research before we actually go out and proactively encourage this.
Is there any indication as to when that information will be available in the UK?
So the last time I looked, I saw that the National Screening Committee in the UK is currently looking at their guidance, so I don't have a timeline, but it does seem to be an active topic at the moment.
Could I follow up just very quickly? Is there any concerns with the current system that obviously accessing via primary care costs? And it costs, I presume it costs to visit the GP and for the blood test. Are there any concerns that there is a group of men who just wouldn't get that far because of the costs?
That is theoretically possible, of course, but I think there are other screening programs where we really would encourage people to go, because we know that they are almost certain to benefit through going through that process. In this particular instance, it's not so clear. So I accept your point, but it's for that reason it isn't our top priority, because there are other screening programs we would really like people to access, such as the bowel cancer screening program.
Is there an evidence base on how this cancer can be prevented?
So it's actually quite interesting, and I don't wish to go into too many technical details, but you would normally expect with a cancer that the earlier you are treated, the better your outcomes. In this particular case, I'm not even sure that that is totally clear. So there's quite a lot for us to understand before we actually develop a campaign around it, but we are keeping a close eye.
Thank you.
Moving on to other aspects of male health, male menopause, andropause kind of work. What education and awareness is currently being undertaken on this?
I have to hand over to Peter again on that.
There's no specific focus on that area. Our focus at the moment is about ensuring that we try to prevent the commonest conditions that are going to harm people's health as they approach older age. So whether we're talking about heart disease or cancer or diabetes, and that has been the focus of our proposals around prevention. Much of this is dependent on securing funding, as we've discussed earlier in the meeting, but we have been doing a few things in the background. So, for example, the screening programs, obviously, as I mentioned, things like bowel cancer screening. There has been progress with some of the vaccination campaigns. So, for example, the acceleration of the shingles vaccination campaign. And we've been working on mental health, as we've heard. So I think the big progress is going to be ensuring that we begin to think about those longer term common conditions, and that's our focus at the moment.
Thank you. Whilst we're talking about vaccines, could we ask how many claims have been made to the vaccine damage payment scheme this year so far?
I'll let Peter carry on because we had a discussion about this earlier today. It's quite
I'm not able to quote a number under 5. If it's what I believe it is 5 or less. I could give you the exact figure, but it's around that number.
Is that successful claims or
they are
claims
the number of
stuff?
claims that have been returned to me. So as you probably know, there may be some that are currently being processed, but they're the ones that I've been returned.
Okay. And were any of the claims for young people, children?
There was no person that I remember being under 18. There are some younger adults.
And were any of the claims successful?
So again, I can say less than 5. So yeah, sorry.
That's okay. I understand. Thank you. Okay. I think.
Yep. And onto the ambulance service and the change of departmental oversight. And is it still the plan that the service moves over to your department minister on the 1st of July?
I understand. Yeah.
Yes, absolutely. So you recall back in 2019 there was a sudden move of the department out of health in the first place, which caused us some issues in the early days because the governance structures weren't in place. So this project has been led by the 2 chief officers of both departments at the moment, and everything is or has been going very well. We've ensured to engage with all the staff involved and the unions and the managers. There's obviously a few concerns with any move, but basically it is a move of line management for myself from one chief officer to another, and everything is on track at the moment for 1st of July.
Thank you. During a scrutiny hearing last year, I think there were some concerns raised about the service, demand and capacity and funding, safety of staff and leadership. Is there a plan in place to address these issues? And is that plan already in place and being worked on, or does it start once the service moves?
Yeah, so there's plans in place to address many of those aspects already. Funding has been addressed previously. Obviously, funding is topical at the moment, given the government's finances. But I guess in any of that, we've been working very closely with the staff and the unions to progress all of that. In terms of demand and capacity, the plans are to run a light review of that. We would hope later this year, if not next. The initial demand and capacity review had led to us taking on more staff, and so we are in a very different position now to what we were when we moved in 2019. So we have a number of elements of our own governance structures in place that will interlink into the health services as we move forward in terms of getting support where we need it, but we've also increased our frontline staffing as well. So notably, we have an extra ambulance on the road during the day at the moment. We're working on the evening period, but we have the staffing in place to do that. So it's ongoing work.
So when you say I think you said a live review, that's looking again. Now things have changed. How are we doing? What's the situation like now? Is that?
Yes, so it was a couple of years ago. So obviously when the review was undertaken, it was done on the year before's data. So in working with the unions, we're looking at, things change fairly rapidly, and particularly coming out of COVID as well. So we want to look again to make sure that is aligned, and some of the concerns around sort of night working and things like that.
Great, thank you. And just finally, I think it may link to that initial review, the States of Jersey Ambulance Service Demand and Capacity Review. Is that the review?
That's correct.
You're talking about? So if I say the status of that review's recommendations, I presume there was a number of them. Could you just give us a quick update beyond, if there's more to add, basically?
Yeah, sure. So business cases, I think it was 2022, so we started early. So 2022-23 gave us the additional funding to put in there. So we've already put the extra ambulance on during the day. We removed our intermediary crew, but put a stretcher service onto the patient transport service. So we've increased the availability on the patient transport service at the same time as the frontline staffing and the management team that followed that, in terms of middle management, to be able to cope with the governance aspects of it. I believe the majority of the actions from that have now been implemented. The one that at the moment we do have additional staff on nights, but we're working with the unions and teams around what that looks like from a specific rostering point of view, because it has to dovetail in with the rosters that we have currently.
Great, thank you very much.
Okay, thank you. And we have a final section of questions for which we have...
Can I ask just
briefly, yes, we have 4 minutes left.
It's just a very quick question. Am I right in thinking that the ambulance service started life in the health department, moved to Home Affairs,
Yes.
and has now come home to the health department?
It will be so, yes.
I mean, what was the purpose of moving to Home Affairs? Well, very briefly, what was the argument?
We were asked to move across back as part of the OneGov restructuring, and I think it was to align the emergency services together. It was done very rapidly at the time and didn't give enough thought, I don't think, it's my own belief on that, didn't give enough thought to the governance structures and what was in place in the health sector. So it has, over time, given everybody is very busy and structures change, it's kind of left us a little bit on a limb from the rest of the health service. So the plan to go back in is to realign all of those structures and make things safer for patients and more coordinated across the healthcare system.
Thank you.
For the Minister's plans.
Thank you. In terms of workplace culture generally, Minister, in your organisation, there have been some recent media reports and members of the public, and members of the workforce talking about not being able to access breaks and working many consecutive days, and also about bullying problems. These 2 issues in the department, can you outline what you're doing to improve those?
We take breaks first. It's been difficult for us to, I'd like Ian to say a bit about this, but it's been difficult for us to actually identify the exact location of the problem, because I don't think the person that reported this was able to even identify the people that had reported it, and the people that had reported it hadn't been specific about any instances where it had been witnessed. So A lot of work's been taking place to try and identify where problems may or may not exist, and have had a great deal of success in identifying the problems. As I say, it was a fairly vague reference in the first place, but I think Ian might be able to elaborate a little further.
It's really helpful. The Deputy Concerned met with me and went through the concerns that have been raised by the islanders. It wasn't clear, unfortunately, about whether they were HCJ employees. They could have been working in other parts of healthcare on the island. It wasn't clear about their profession, and it wasn't clear about their department. So it was very difficult to tie that down. So we've been trying to do that. What we have done is to go back in and do some due diligence. So you'll know that we have an e-rostering system, so all of our staff, apart from doctors, who will be rostered this year, are currently rostered. That rostering system doesn't allow illegal shifts. So it would mean that there would have to be an operational change beyond the planned rostering of people, because the roster system doesn't allow back-to-back shift, it doesn't allow non-breaks, etc. Obviously, a local operational manager could be maverick and could say you can't take your break today. We do know there are instances where people are unable to take breaks, where shifts are particularly pressurised. What we do is that we provide the break in terms of time in lieu. So we have procedures in place where there are extreme service pressures, and somebody can't get away for their break. So we've forensically looked at all of the shifts, which we do on a monthly basis anyway, as we plan the rosters going forward. We've been into the departments that we think there may be the problems. We've asked staff, we've been unable to establish anywhere any evidence of the stories that we've heard.
Okay.
We've spoken to our union colleagues, and the unions obviously in the press sort of said, yes, everyone should have breaks. When we asked them, it said, has anyone come to you and complained they're not getting breaks? No. So
Questions around bullying and around rest breaks.
there are, yeah.
Okay. And do you think there's sufficient questions around bullying and around rest breaks?
there are, yeah.
Okay. And do you think there's
And
sufficient to
our
identify?
metrics on those have been improving year on year.
Right.
So I'll just beg a tiny amount of your time. So because of the noise around bullying, I actually put out a communication to staff to say, please come and talk to me, open door policy. Interestingly from that, and I'm sure we do have bullies, we have people in our organisation, they are humans, so nobody's perfect. But actually of the people that came forward to report bullying to me, as we've unpacked those, 3 of the cases of people came forward actually were people that were in performance management. So because we have a culture whereby we try to manage people's performance, you can define that as bullying, because actually it is behaviour that you don't wish to receive. Your manager telling you that you are not doing your job well enough and assisting you to do it better is perhaps behaviours that you don't wish to receive, and you could experience that as bullying. So it's been interesting to get under some of the rhetoric about bullying, and it's often not as obvious as it seems to be on the face of it. But yeah, the Freedom to Speak Up Guardian and I work very closely on this with them. We take a very, very serious view of bullying, and the cases, as I say, that came to me through the extra communications we did, we've taken those very seriously. We do have cases of bullying, and we deal with the bullies very seriously.
You had them identified in Royal College reports. Have you made progress on those specifics?
So there's all the Royal College reports have also got their action plans. We have to continue working across the whole of our culture. Obviously, the Royal Colleges are particularly pointing towards the culture amongst our medical colleagues and consultant staff. And the medical director and myself are very cited on the work that we need to continue to do with the medical body in terms of those historical behaviours.
Thank you.
Okay. All right. Thank you very much for your answers to those questions. Minister, we've come to the end of the hearing. Is there anything that you would like to add before we close the hearing, or your Assistant Minister?
No, I don't think I've got anything to add. I think we've covered most things.
Thank you.